Thank you, sir. Uh, Good evening and namaste to everyone. I would like to thank you, ICCCM and our Regional Nursing Director, Usha Madam and Sirisha Madam, for giving me this opportunity and selecting me as a speaker. Now, I would like to start my presentation with a case scenario. A 26-year-old male came to the emergency with the complaints of high-grade fever, myalgia, vomiting, retroorbital pain, and headache since 3 days. On physical examination, we found that patient was having fever with 104 °F, hypotension 85 by 60 mm of Hg, tachycardia 136 beats per minute, and generalized petechia. Petechia is nothing but a small red spots, red or purple spots on the skin. And the laboratory study shows mild leukopenia. It is decrease in the WBC count, and not anemia, and thrombocytopenia is nothing but the decrease in the platelet count. LFT showed mild transaminitis, that is the increase in the liver enzymes. He also have the history of epistaxis that morning. Epistaxis is nothing but the bleeding from the nose. Then how can we suspect the patient with the dengue? Dengue fever should be suspected in the patients with fever and other manifestations like headache, nausea, vomiting, myalgia, retroorbital pain, rash with or without hemorrhagic manifestations, often associated with leukopenia. Positive tourniquet test. How to do a tourniquet test is we have to first measure the patient's blood pressure. For example, if the patient blood pressure is 100 by 70 mm of Hg, then we have to inflate the midway, that means the between the systolic blood pressure and diastolic blood pressure, that is 100 plus 70 divided by 2. At 85 mm of Hg, we have to inflate the cuff, BP cuff, then release it and wait for 2 minutes. If the patient is showing red spots on a hand above 10 in a square inch, then we consider as positive tourniquet test. We identify the dengue fever even with the positive tourniquet test. And if the patient is having any history of past 2 weeks in endemic infection area, then we have to suspect dengue fever. Then now we'll see in detail about dengue fever. Dengue fever is also known as breakbone fever because of the severe myalgic pain the patient will suffer. So they say the other name as breakbone fever. Then it came from the family flavivirus family, and it is caused by the vector Aedes aegypti mosquito. And that virus has a single stranded positive RNA and 4 distinct serotypes, that is dengue 1, 2, 3, and 4. And it has the incubation period between 3 to 14 days. Now we'll see the mechanism. When a mosquito carrying dengue virus bites a person, the virus enters the skin together with the mosquito saliva. It binds to enter the bite blood cells and reproduces inside the cells while they move throughout the body. In severe infection, the virus production inside the body is greatly increased and many more organs can be affected. And the fluid from the bloodstream leaks through the wall of small blood vessels into the body cavities. As a result, less blood circulation in the blood vessels and the blood pressure becomes low, that it cannot supply the sufficient blood to the vital organs. So the virus can also suppress the bone marrow, which leads the reduction of the platelets, which is necessary for the effective blood clotting. This is the major complication of the dengue fever. So the virus can be transmitted only through the vector mosquito, but in rare conditions, it might either transmit through the via blood products. Organ donation and transfusions have been recorded. Which is very rare, and even maternal transmission also have been identified. If the pregnant mother is affected with the dengue fever, the baby might also be affected, which leads to low birth weight and low birth weight and preterm labor, so which is also very rare. Then we'll see the reinfection. If, as we have earlier seen, that dengue virus is having 4 different serotypes. If dengue fever is if the patient is affected with the one serotype, the body will attain the immunity of that serotype only. If the patient is reinfected with a different serotype, it is usually more severe compared to the first infection due to the cross immune reaction of the body. Then we'll see the symptoms. The common symptoms of the dengue fever are eye pain, muscle pain, joint and body pains, fever with high grade around 104 degree Fahrenheit, and severe headache, nausea, vomiting, and rash. So these are the few warning signs which has to be focused. The few warning signs are abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation in the chest and abdomen cavity, mucosal bleed, lethargy or restlessness, and the liver enlargement more than 2 centimeters. And laboratory findings also shows increase in the hematocrit that will concurrent to the rapid decrease in the platelet count. So according to the WHO classification, recent edition in 2022, dengue is classified into two, dengue and severe dengue. The normal dengue might be with or without warning signs. If the patient is having with the warning signs, then it should be strictly observed and medical intervention to be taken. And if the patient is showing any severe plasma leakage and severe hemorrhage or severe organ impairment, it is called as severe dengue. Now we'll see the phases of infection. The dengue fever have 3 phases: febrile phase, critical phase, and recovery phase. Febrile phase will have the high grade fever and often around 104 degrees Celsius, and it will be between 2 to 3 days. And it shows the symptoms will be generalized weakness, some petechiae, so small red spots, headache, and rash. Next is the critical phase. In critical phase, which follows after the resolution of the high fever, and it will last for 1 to 2 days. During this phase, the significant accumulation in the chest and abdominal cavity will be seen, and oral organ dysfunction and the severe bleeding, and typically from gastrointestinal tract. During this critical phase, the symptoms will be like ascites, pleural effusion, and hypertension, and gastrointestinal bleeding. The next is the recovery phase. In this phase, the resorption of the leaked fluid will be into the bloodstream, and this phase lasts for usually 2 to 3 days. We feel like the recovery phase means the patient will recover, but it might lead to complications like seizures and low heart rate as well. Then how to diagnose the dengue fever? With what investigations? The first main investigation is the complete blood picture, which shows the thrombocytopenia, that means the low platelet count. It depends on the severity of the infection. And there is also increase in the hematocrit due to the capillary leak. And the other investigations are by dengue NS1, that is non-structural antigen. Then the serological methods may confirm the presence of recent or past infection by detecting the anti-dengue antibodies like IgM and IgG. IgM will be seen after 1 week of the infection, and it remains until 3 months in the body. So the IgM positive of the IgM, dengue IgM, indicates the recent infection. If the patient represents the IgG positive, then it indicates that a patient is having a past infection, because it remains in the body for years. Then we'll see the management. Due to the capillary leak, the dengue fever will cause dehydration. So the patient mainly there is no proper specific treatment for dengue fever. There is only we can do is the oral rehydration therapy, symptomatic treatment, and IV fluids. If required, blood and blood products transfusion. In oral rehydration therapy, we have to encourage the patient to take orally plenty of fluids, as the patient will lose water with a high fever and vomiting. Then IV fluids administration is indicated for patients with dehydration due to capillary leak. Only when the patient is symptomatic, but like internal gastrointestinal bleeding, may require transfusion. Then why to transfuse IV fluids? One of the complications of the dengue is dehydration. which not, if it is not monitored or treated carefully, the patient will land up into a shock. So the main treatment for the dengue fever is only IV fluid therapy. So the recommendation of the IV fluid is administering 0.9% of normal saline at the rate of 20 ml per kg per hour. Then when to transfuse the blood or platelets to the patient, irrespective of the bleeding manifestations. If the patient's platelets are 10,000 or below 10,000, we have to transfuse the platelets. And if the patient is having any bleeding manifestations like gum bleeding, melena, or hematemesis, then hematuria, even if the platelets are about 20,000, we have to transfuse the platelets. The next we'll see the advantages and disadvantages of SDP and RDP transfusion. Each RDP bag will raise platelets of 5,000 to 10,000, whereas SDP will increase up to 40,000 platelets, which is equal to 6 to 8 RDP. Then RDP, for transfusing RDP, we need multiple donors, whereas SDP requires only single donor. Then increased chances of infection are more in RDP transfusion as it requires multiple donors, whereas SDP has less chances of infection. And even fluid accumulation, fluid overload is also a chance of RDP during RDP transfusion, where it is less in SDP. Then RDP is easily available in all the centers and even in the small centers. And whereas SDP is not available because it requires an equipment, special equipment. So SDP is available in only higher centers. And RDP is economical, whereas SDP is expensive. Coming to the nursing management, the nurses should be assessed focused mainly on the evaluation of the vitals, as dengue fever will cause hypertension and low heart rate. So we have to focus on the monitoring of the vitals and evaluation of the skin color. And the strict IO chart should be measured, as it causes dehydration, which is, when it is not treated, it may lead to shock. So we have to morely focus on the urine output IO chart strictly. Then evaluating the bleeding manifestations, because it is a complication of the dengue fever, like gum bleed, hematuria, or hematemesis. So we have to evaluate whether the patient is having any warning signs or any complications of dengue. So nursing interventions are blood pressure monitoring, which is a which plays a major role in nursing management, and monitoring pain, as dengue fever will have myalgia and body aches and severe body pains. So patient, we have to focus on monitoring pain as well. Then vascular access, we have to check whether the patient is having proper vascular access, because we have to transfuse the blood whenever it is required, and we have to even transfuse the IV fluids. So we have to check the accurate vascular access. Then next is the medication regimen. We have to see whether the patient is on aspirin. We are not supposed to give aspirin because it will further bleed. It will lead further complication for the patient. So we have to check the reconciliation medicines, whether the patient is on aspirin or non ibuprofen, which is which has the anticoagulant properties. So we have to see the reconciliation and inform the doctor immediately. Then the fluid replacement therapy, as we discussed earlier, we have to strictly monitor on fluid. Then how to prevent? We have to avoid the crowded places, and using of mosquito repellents and mosquito-free environment, and avoiding of the stagnant water where the mosquitoes will grow more. So we, as a nurse, we have to prevent ourselves, and we have to educate the patients as well as the family members to prevent ourselves from the dengue fever. And wearing of protective clothes or using mosquito nets, and staying of indoors during these climatic situations, and using the mosquito repellents. And coming to the vaccine, the first dengue vaccine, Dengvaxia, developed by Sanofi Pasteur was licensed in December 2015 and has been approved by regulatory authorities in 20 centuries. WHO says that this vaccination should be given to the affected person who is affected earlier with the dengue only, and it is not approved in the India. So we did not take any dengue vaccination till yet. Thank you.
Thank you, Ma. It's a nice way of presentation. And any questions for this? Any discussion? Like, a thing is, as you said, the WHO classification, there are two varieties, no? That is severe dengue or dengue with some shock. So, what is the previously we known to have? How it is changed from the previous one? Do you know anything about that? Spandana.
Dengue shock syndrome, sir.
Yeah. So what are the, you have already told about that warning signs of dengue, no?
Yes, sir.
Yeah, it is there in the already presentation. So now it is open for discussion, and anybody is having any questions, I would like to take the questions. Spandana will answer or else I will answer. Any questions? Can you read out? And I am not able to see any questions. Yeah. There is a question from, I don't know who it is, but it is what is the safest antibiotic if there is a secondary infection? Is it so? So basically the problem is in the first, as you said, it is secondary infection. Initial phase of dengue, because it is a viral infection, we don't require any antibiotic for these patients. But if there is an like occurrence of the secondary bacterial infection, usually after 5 to 7 days of extreme dengue cases, we can identify the possibility of having infection where it is, whether it is in the urinary tract infection or it is anything like having a central bloodstream infection or having a respiratory infection. We have to identify those things, and depending upon that, our hospital, because patient is already in the hospital, developed a secondary infection, we need to look into our hospital antibiogram. What are all the commonest bugs in the last 6 months dwelling in the urinary tract, dwelling in the respiratory tract, or what are all the blood infections like cultures are showing. So depending upon that, we can, depending, one thing is the shock situation, hemodynamically stable, unstable, patient respiratory infection, we go with basic BL-BLA combination, or when it's like urinary tract infection, it is basic BL-BLA combination. So likewise, we need to go into the catheter-related bloodstream infection. Better to add an MRSA coverage or gram-positive coverage. So this is how we have to discuss, and we have to identify and suit the antibiotic depending upon the hospital antibiogram. So that is question answer to the safest antibiotic. Next comes kidney failure patient, how volume replacement will affect to. Exactly. This all depends upon the, it is not that we have to look into the whether the vascular compartment is how the adequately it is filled, because we know that it is a capillary leak, patient may have a dehydration. In dehydrated patient, we need to give fluids irrespective of the kidney function. And if they, at one point of time, if you identify that there is a fluid overload, because our target is to normalize the hematocrit, stability to the platelets, not allowing to ongoing platelet lysis. So if you feel that patient is overhydrated, then anyway we are sorting out to dialysis. But looking at the kidney failure, there is no contraindication to give fluids. We have to fill the compartments because there is capillary leak is happening, and that is the reason for the shock and platelet lysis. Anything like, am I missing something? Any patient who is on aspirin, aspirin is contraindicated. Some question is there any ischemic heart disease patients? Can we discontinue aspirin if patient having dengue? Yes, we can hold an aspirin, but most of the times we have to look about that, what is the platelet count and how much it is actually affected. And we can restart once the platelet count is getting stabilized, because aspirin causes thrombocythemia. So already platelet count is low and thrombocythemia means platelet function is at deranged. So all these, a combination effect will be there. So better to stop aspirin even it is ischemic heart disease patient. Any special consideration in antenatal period dengue positive status? Don't do any active procedures because patient platelet count is low and there is a estimated there is some blood loss will be there. So don't do any active procedures like any episiotomy or any abortions or like something like planned cesarean sessions. These things should be avoided in the acute phase of the dengue. Once the patient is stabilized, we can sort out for these procedures. Otherwise, if possible, postpone all these procedures, and if required to do it under a platelet backup, like SDP backup, and properly hydrate the patient, and do not allow the patient to go into hypovolemia. These are the precautions we need to take. Then we give steroids for post-viral myalgia, discharge, and later on follow. See, basically, when the patient is, we know the reason for the drop in the platelets is dengue infection. So steroids have no role in this patients. But I don't know why it is being given here like post-viral myalgia. So usually, I don't think even any, if it is not dengue, any other viral myalgia, steroids are not indicated as such. Okay. Any role of doxycycline in treatment of dengue fever in any stage of illness? No. Doxycycline is an antibiotic. I don't recommend any patient who is having dengue. No, not necessary. But if there is a secondary infection, treat the secondary infection with appropriate antibiotic. I am not recommending doxycycline as per se. What is the role of albumin in dengue shock syndrome? Yes. If you want to consider it as a fluid of resuscitation, albumin is still holds back on the fluid of resuscitation. No need of sorting out to albumin. Still crystalloids like normal saline is the fluid of choice for resuscitation in the dengue. How to rule out respiratory failure in a UTI infection and dengue? Great. Respiratory failure, the definition itself says that patient is tachypneic, patient is hypoxemic, and patient is increased work of breathing, which is easily resolved by putting the patient on NIV, this thing. So it is very easy to rule out a respiratory failure in an UTI patient, but think that there should be a combination. If the patient is severe urosepsis, patient will be having already having a respiratory issue, because when there is a severe urinary tract infection, patient going into septic shock, and the septic shock is a condition where you require oxygen, demand is more or extraction is less. So at that point of time, patient will be having high respiratory drive, appears to be patient in the respiratory failure. So because diaphragm is the big muscle in the body, when the patient lactates are going bad, whatever the oxygen is available, that is being sucked by the diaphragm to maintain its viability. So rest of the tissues are getting hypoxemic. So these are the situations where there is nothing like separation. Treat both the things. Thus respiratory failure needs a respiratory support in the form of NIV or invasive ventilatory support. Anything I missed? Please retype, because my window is not showing. Hopefully I addressed all the questions. Anything? Yeah. Role of papaya extract tablets to improve the platelet count. We don't have any idea about this because it is not in our purview. It is like non-allopathic medications. So as per se, I don't recommend any papaya extracts in such patient. There is no literature proven that. Any more questions? Spandana,
Sir.
do you want to add anything in this? Somebody raised the hand. Can you allow them to talk? Okay. But somebody raising their hand, they can type their questions there, please. Yeah, colloids versus crystalloids. That is in the management of any shock. First fluid of choice is always normal saline, and normal saline, nothing more than that. Okay. So colloids, when definitely colloids have its own side effects, like colloids will have altered coagulopathy. Already this patient is having low platelet counts. I am adding another hit over that. Patient may have a deranged coagulation profile. So ultimately it leads to worsening of the bleeding. So role of colloids, even in the normal septic patients or in the dengue shock syndrome, we don't recommend there is no recommendation saying that colloids preferred. Always it is normal saline, crystallite solutions are accepted. Colloids has no role. See, this is a specific question, like how much time platelet transfusion rises platelet count incline. Okay. So this question I cannot answer, but I can answer the contradictory of that. The raised platelet count may not be sustainable for 24 hours. That much I can say, because when there is an ongoing platelet breakdown, whatever the platelets you are supplementing exogenously, obviously will have the same effect and they will get lysed off. So we are giving that platelet count to buy some time to prevent bleeding because of the reduced platelet count, but those platelets won't stay in the body for longer periods. Usually we have seen that after even giving an one SDP at the baseline of 25,000 or 30,000 of platelets, because of some scariness with the public demand or patient demand, we give platelet count and there is no improvement in the platelet count. Many times we have seen. That's why it is happening, because the same process of lysing the endogenous platelets is applicable to the exogenous platelets also. So there is a breakdown of the platelets and you don't get an adequate number even after transfusing one SDP. So I can't give you the enough time how long they will stay, but definitely say that they will not stay beyond 24 hours. In this stage, what is the preferable antibiotic in first stage? And so specifically, I'm telling there is no role of antibiotic in the first 5 to 7 days. It's very clear it is a viral infection. Second part of the question is NL6. NL6 is simple paracetamol, that's enough. When to transfuse platelets? It is clearly Spandana told when there is no obvious bleeding, but still platelet count is less than 10,000, we need to transfuse platelets. If there is an obvious bleed, even if the platelet count is 40,000, 50,000, we found that there is epistaxis or bleeding, something is there, we have to transfuse platelets without looking at the figure. But if the patient count is low, less than 10,000 platelet count, but there is no bleed, still we transfuse. So there are only two conditions I'm telling. Absolute platelet count less than 10,000, transfuse platelets. Whatever may be the platelet count with the background of dengue fever or dengue hemorrhagic fever, when there is an obvious bleed, transfuse platelets. That's all. Does diet plays any role? I mean, any type of diet, not only papaya, any kiwi. God knows, sir. I really don't know answer for this because I never had any I just go through the literature, but none of the literature supported any dietary supplementation. Any more, sir? Spandana?
No, sir.
Shall we end now? If no more questions. ఎవరండి చెప్పండి ఒక్క నిమిషం if not urgent I'll call you after 10 minutes. I'm in my webinar. Okay. What to do, Spandana? Shall I sign off?
Sir, questionnaires, sir.
Still questions are there?
No, sir, questionnaires.
Okay, yeah. I'll allow me to share my screen. Hello, can I share my screen? This will stop other screen sharing. Yes. Can you see my screen? How to look into this? Yes. Are you able to see my screen? Hello?
Yes, sir.
Hello?
Yes, sir, we can see, sir.
Yeah. So how to go ahead, Amma? You want to read or should I read?
Sir, you read, sir.
Most virulent serotype of dengue fever? Type 1, type 2, type 3, type 4. So they need to type in their window, short window.
Yes, sir.
So these are there are 6 questions here. Please answer. I put the alphabet there against your name and put it in the chat box. Okay. The most virulent serotype of dengue fever, type 1, type 2, type 3, type 4. Next comes the causative agent of dengue fever is tangovirus, paramyxovirus, varicella virus, arbovirus. What is the extrinsic incubation period of dengue fever? Is it 8 to 10 days, 2 to 10 days, 9 to 18 days, 8 to 30 days? What is the extrinsic incubation period of dengue fever? Question number 4. Classical dengue fever is also called as black fever, breakbone fever, saddleback fever. It can be both breakbone fever and saddleback fever, both B and C. The classical dengue fever is also called as black fever, breakbone fever, saddleback fever, both B and C. Question number 5. Warning signs of dengue hemorrhagic fever: blood vomitings, breathing difficulty, shock, all the above. Warning signs of dengue hemorrhagic fever: blood vomitings, breathing difficulty, shock, all the above. Last question is medication that are contraindicated in management of dengue: paracetamol, aspirin, pantoprazole, fluids. Again, I am repeating medications that are contraindicated in management of dengue: paracetamol, aspirin, pantoprazole, fluids. There ends and questions. So I'm repeating from the first question. I'll just see the chart box once. Yes. Question 5 is D. Okay, you check among yourself. Anyway, I'll give you the. So again, I'm coming back for a few people who may not follow. Question number 1 is, what is the most virulent serotype of dengue fever? Is it type 1, type 2, type 3, type 4? Second question is, what is the causative organism? Dengue fever: tangovirus, paramyxovirus, varicella virus, arbovirus. What is the extrinsic incubation period of dengue fever? Question number 3, 8 to 10 days, 2 to 10 days, 9 to 18 days, and 8 to 30 days. Question number 4, classical dengue fever is also called as black fever, breakbone fever, saddle fever, the saddleback fever, both B and C. Question number 5, warning signs of dengue hemorrhagic fever: blood vomitings, breathing difficulty, shock, all the above. Question number 6, medications that are contraindicated in management of dengue: paracetamol, aspirin, pantoprazole, fluids. So there ends the questions. So you want me to like tell me the answers and correct yourself. Most virulent serotype of dengue fever is, just go through. I don't want to give you wrong answers. It is answer. Answer is B, type 2. Mark type 2. Answer B is the correct one. Okay. Then what is the causative agent of dengue fever? It is, answer is D. D for Delhi, arbovirus. Okay. Question number 3. What is the extensive incubation period of dengue fever? It is 8 to 10 days. Answer is A. Classical dengue fever is also called as, it has two names, breakbone fever and saddleback fever. So answer is both B and C. Warning signs of dengue hemorrhagic fever, all the above. All the above. Answer D. D for Delhi. Then medications that are contraindicated in management of dengue is, answer B. B for Bombay, it is aspirin. Okay. Got it. So I think it's over. Shall we close this session? Yeah, there is a question. After transfusing 1 or 2 SDPs, when will we test for its level of blood? Usually after 6 hours. There is no specific time frame, but normally when the level is dropping down, we frequently check the blood platelet count. So give the SDP. No need of giving 2 SDPs. Now 1 SDP will raise roughly around approximately 40 to 50,000. Give 1 SDP and see the platelet count, whether it is in the uptrend or not. If not, it is improving, then repeat one more SDP. But you need to identify the reason. Unless you hydrate the patient properly, platelet will not hold there, because the first main treatment is hydration of the patient is very important. Okay, so better to treat the underlying cause, completely prevent the capillary leakage or hydrate the patient, then temporarily your SDPs will help you. If the SDPs are not holding on, still platelet count is low, our level of hydration is not correct. How to manage the capillary leak? Hydration, that's all. Right, sir? Shall we close? Spandana, close.
Yes, sir.
So thank you all. Thanks, Spandana. Thanks, ISCCM, for giving us this opportunity. Ever be thankful to you all, and very good academic activities happening from the nursing point of view, steps in, and would like to see more like this. Thank you very much.
Thank you, sir.